Hi. Hello, everybody. I'm so honored to be able to be here. This is a really great group, and I think it's a really great mission to be able to talk about how we can attend to patients with opioid use disorder, addiction, and also with pain, because it's a real cohort of people that have these. So first, I'm going to just let you know I have some disclosures. But just let's go over something. It's a fun discussion. It's a kind of a sad story, but we're going to really briefly go over a history of opioid use because a lot of people kind of come to the table thinking, well, this is a new problem, or it's a pharmaceutical industry thing only, or it's doctors. But we've been using opiates. Humans have been using opiates, and I dare say animals for longer. But the first documented opiate use was in 3400 BC, called the joy plant. And then it came, you can just step through this history. I'm not going to go through it in detail, but in 1804, we had the first isolation of morphine. And then we had some treatment, or we used in the 1850s. Hypodermic syringes were a nice Christmas present. You could get a bedazzled syringe for a Christmas present for your lovely lady. And then morphine use increased in the Civil War. Laudanum and morphine was highly used. And then in 1874, heroin was then synthesized as a non-addictive alternative to morphine. We've heard this before, right? So then 1898, Bayer, I worked at Bayer not in 1998, but in 1898, commercial use of heroin began. It was a wonder drug for cough and for pain. Here we go. It was even used for children suffering from colds and teething and irritation. It was used for women who were suffering from, I'm going to put in quotes because it's an old thing, hysteria. Anyway, so that was from the 1890s up until 1912. It was used widely from a pharmaceutical perspective. Keep on going. From the early 1900s, we had some treatment where heroin was used to help morphine addicts stop. And then we had some laws around people with addiction, barring opium smoking. 1914, I should highlight this in my presentation. This is huge. The Harrison Act was written in 1914, and it was a very massive document about taxation of opiates in particular. But there was one line in there that said, that it required physicians and pharmacists to pay a tax and registration to dispense opiates. And it also said something about opiates not being able to be used to treat people with opioid addiction. So today, the root of our restriction of some of our prescribing to help people with opioid addiction stems from this 1914 act. Anyway, so we go forward, and then in 1916, you may not know how long ago this was, Germans synthesized oxycodone, and it was helping pain and being less addicting than heroin. Remember, it went from morphine to heroin to oxycodone. And then some treatment happened, and church programs developed. The CSA, Controlled Substance Act, scheduled the drugs in 1970. And then we had the resurgence or the increase of recreational drugs. And then the 70s, and methadone starting in 1972, which was incredibly regulated. And then in 1973, one of my mentors, actually, he discovered that their opioids receptors were in the brain. And so interesting that, that he was able to pinpoint that. And now we have a little bit more of the biochemistry. We then go to the war on drugs in 1973, and we keep on going, and here we are today. So 2018, the American Society of Addiction Medicine has a text that was on pain and addiction, and it's a guide for primary care prescribers. So that was an opening of the manual for kind of how to deal with folks with pain and addiction. Okay, most of you are in Illinois. Some people are in other states. I'm in Louisiana. But this is just kind of a prescription of how many number of painkillers prescription per 100 people. And so it spans all the way up to 140 prescriptions per 100 people in certain states. In the red, Alabama, Tennessee, Kentucky, and then my state, Louisiana, is 118. And then there we go. Illinois is 68, and that also varies region per region. So this is what we're doing. This is what we're up against. And if we look at these numbers in 2012, 11% of adults report having daily pain in the United States. Only 6% of patients with an initial prescription remained on an opiate 1 year later. However, this was this big study in JAMA in 2017, the percentage more than doubles if the initial prescription for opioid pain pills is for greater than 8 days. And then when the prescription is for greater than 31 days, the risk drops to 30%, to less than 30%. I think that's backwards, I'm sorry. When the prescription is for less than 31 days, the risk jumps to 30%. And so we need to think about what we're doing as prescribers. Some of us, I'm specialized in psychiatry and addiction medicine, so I'm not prescribing pain pills. I'm prescribing buprenorphine for people with opioid addiction, but my colleagues in the pain world and primary care, special rural primary care, we absolutely need to address pain appropriately and safely. And so knowing some of these numbers is helpful so that we can abide by the CDC new guidelines and the DEA new guidelines, but also treat our patients. So I don't want to villainize, that's why I showed the history, because I don't want to villainize prescription pain pills, but loose prescribing without the deep knowledge of some of the stats can be part of the problem. It not always is part of the problem, but loose prescribing can be part of the problem. So 25% of patients in traditional pain management, in legitimate pain management prescribed clinics, exhibit non-adherence. Now that means that 75% or more exhibit adherence. And so that's great, but we need to be attentive to that 25% that might be misusing or diverting. Well, this is a graph that shows about how we got to this massive opioid crisis, as we have been calling it. So we know that we had a rise in prescription opioids and overdoses because of prescriptions, because of actual prescriptions coming from the doctor's office starting in the mid to late 90s. Actually, that's the yellow is the commonly prescribed opiates. So that would be, like I mentioned before, oxycodone, which was developed in Germany long ago, and then OxyContin in particular was part of this wave. And then the heroin overdoses maintained steady state until 2010. And then as did synthetic opioids all the way until 2013. But then when, there's a supply and demand, we have a lot of people exposed to opiates through legitimate pain prescriptions. You all know all about these seemingly legitimate, but illegitimate pill mills that were really big when we, and if you haven't seen The Pharmacist or haven't, listened to any of the reports on Purdue and Janssen and Johnson & Johnson, then it would maybe benefit to just look at that. There's another film that just came out the other day on I think Netflix, and it was called The Crime of the Century, and it's about a journalistic investigation of these pill mills and also the pharmaceutical industry's involvement. There's movies called OxyContin Express, and then another one called I'll come up with it later. There's some great names, and there's some really interesting stories and understanding of where we were in the early 2000s all the way until 2010. And then in 2010, when we started restricting pain prescriptions, it was very difficult for some people that were, physiologically dependent when their doctors stopped. Either some of their doctors got in trouble and some of their doctors stopped prescribing them. So it was very difficult for them. And the street pharmacist, like the drug dealer, knew that. And so heroin and synthetic opioids, such as fentanyl, specifically illicitly manufactured fentanyl, not the stuff that we get in the ER or in the OR. And so this is just something to touch on, kind of how we got here, and here we are. Okay, so we need to differentiate between dependence, which is physiological. There's neuroadaptation, tolerance, withdrawal, but it doesn't include some of the behaviors of addiction. So addiction, opioid use disorder, includes cravings, continued use, compulsive use despite harmful consequences. And it's because the brain chemistry changes and like the dopamine reward system is hijacked. And so that's how we end up with addiction. Some people have dependence and don't have addiction. As I mentioned, only 25% or less of pain clinic patients actually have misuse or diversion. And so not everyone that takes an opioid ends up with addiction. But what I mentioned before is we do know that there is the longer you use, the longer you continue to use. So if an ER doctor were to write a prescription for 15 days of, you can look at the graph, 15 days of the first opioid, then it would be a 30% or 25% 1 year probability of continued use for a year. 1 year and then on the broken graph on the bottom, it would be a 15% likelihood of continued use for 3 years. So this is a great study. My pain colleagues and I kind of split hairs over some of this, but it was a very large study. And I see the ones that misuse and they see the ones that don't. So, so we have to meet in the middle, and that's what this presentation is about. Well, how do we get into opioid use and this is the opioid continuum. So I did a kind of Word document trial of drawing this little graph, but we start with taking opioids, so opioid use on the bottom left, and then it can go to opioid dependence, i.e. physiological dependence with tolerance and withdrawal. It can go to opioid dependence for as soon as 7 to 10 days for some, and that depends on a whole slew of risk factors, from pain to genetics to environment to a whole slew of other things. And then some people, not everybody, goes from opioid dependence to opioid use disorder. And then at some point, opioid discontinuation looks like jumping over this wall. If I were to be able to be a better graphic designer, I would have made that into a brick wall, because that brick wall is a very hard thing to surmount. It is, if you have seen people in opioid withdrawal, it is not something I would wish upon anyone. It is very painful. And then after withdrawal, during withdrawal, we use withdrawal management. And then after withdrawal, we use post-withdrawal recovery. And so some patients, those that have addiction, I 100% want everyone that has addiction that goes through this process to cover their opioid receptor. And we'll talk about what that means. But for those that don't have addiction, that have dependence and physiological withdrawal, they might not need to cover that opioid receptor, so to prevent behavioral manifestations or relapse. So opioid use disorder, a lot of people, 2.5 million or more, a lot of money. Opioid overdose quadrupled from 99 to 2015. And then in 2016, 91 people were dying daily of opioid overdose. However, the stats that I heard in the past week that were summarized for the CDC were 270 something people dying. So 91 in 2016, now 270. So I think of rational prescribing, and I have to explain what prescribing is to judges, because I work in the court systems. I teach in a lot of conferences that are psychiatry and behavioral health conferences. I work in the drug courts, and I also teach at some of the universities. But rational prescribing, the rationale for rational prescribing by using medication-assisted treatment is that it's like for like. So for those of you that are thinking of, one of my easiest addictions to talk about is nicotine, because we all know, not everyone knows someone intimately that has struggled with opioid addiction or with cocaine addiction, but we all know someone. that has struggled with nicotine addiction. We all know someone that smoked, and some people smoke and they just have a cigarette and then they stop and no big deal, or they'll have a cigarette just when they go out on the weekends and then they never crave it again. That's a genetic safety net for that's a genetic situation for that individual. Some people smoke and they'll have 2 cigarettes and just like they're on and that's it. They're like, I feel great, this is what I need to do, and then their body says that they need to keep smoking, their brain says they need to keep smoking. So on the bottom right you'll see a red text that says nicotine. Nicotine attaches to the acetylcholine receptors, and when we use medicines, and on the top middle, nicotine and alcohol also have effect on the opioid peptide receptors. So when we use nicotine, we hit the ventral tegmentum with a signal, and that signals a release of dopamine that flies out into the nucleus accumbens, hit those receptors. Another secondary message goes up to the opioid peptides, sends some opioids out, hits some GABA, and then this cycle continues from the ventral tegmentum, nucleus accumbens, opioid, GABA, cycle, wanting more. That cycle is do it again, give me more, give me more. I have some people that say that they have one puff of the cigarette and they haven't smoked in a while and their brain is already ready for the second cigarette, even though they haven't even finished the first cigarette. Same with some people with chocolate cake. We don't have a chocolate cake receptor here, but it still is related to dopamine. And so we have medicine. And this is when I explain this to people that are not wanting to use medicine. Oh, it's just trading one medicine for another, one drug for another. We have medicine that really helps this. So varenicline, Chantix, it sits on the same receptor that nicotine attacks. And so it sends a partial signal that's a padded down signal, so lower dopamine. So if you talk with someone that has taken varenicline, Chantix, they may say, oh, cigarettes don't taste good anymore, or they don't give me that high anymore, or that buzz, or I don't like them. I only get the nasty taste. Also, we know that Zyban is the prescription, is the brand name for bupropion, which is also Wellbutrin, and that works as a dopamine reuptake inhibitor at the dopamine receptors right over here in the middle between the ventral tegmentum and the nucleus accumbens. Both varenicline and bupropion are FDA approved and indicated and very effective for treatment of nicotine use disorder. This is why, because it's like for like, sitting on the same receptors, blocking the receptors. Guess what? Buprenorphine does the same exact thing at the opioid receptor up at the top right and in the middle left. Naltrexone does a little bit different thing at the opioid receptor by blocking it. I don't have methadone on here, but methadone also does a different thing, but also at the opioid receptor. So this is the rationale for prescribing for people with a use disorder, and whether that is a severe opioid use disorder or mild, or even physiological dependence where they're dependent but they need to cover their pain. So that's what we're going to talk about more. So I usually stabilize on medications and then really check and see every month to see if we want to move away from medications, if the safety net is covered. If someone has opioid use disorder, then I want to cover the opioid receptor with an abuse deterrent product, and then treat symptoms, and then just check in and see if life has changed and they might not need this medication long term. But I have some patients on buprenorphine for 10 or more years. So beyond opioids, there's lots and lots of stuff that we can do for pain, and especially pain management. So we're not taught all of this in medical school, but non-opioid pharmacological treatment we are taught, but we don't think of it as treatment for acute pain, because we have something called painkillers, which painkillers treat pain, right? But anti-inflammatory agents, there was a study that was released that shows that Tylenol and ibuprofen compared Tylenol and ibuprofen 4 times a day together, not switching back and forth, was superior for certain ortho postoperative pain to opioid pain pills. Serotonin norepinephrine reuptake inhibitors. We use things like duloxetine, or some of the other ones, even amitriptyline, are some of the triptans can help. Membrane modulators. Interventional treatments, we all know about nerve blocks and ablations, and they're implantable devices. Of course, surgery is an option for people with severe pain where they can have a curative or partially curative from a surgery. Non-pharmacological treatment is great. There's a lot of good stuff like digital therapeutics, cognitive behavioral therapy, acceptance and commitment therapy, mindfulness-based cognitive therapy. All of these are evidence-based. Some of these are FDA approved. The digital therapeutics are FDA approved, and I think I get into that a little bit more. Pacing worksheets are great because we can help people kind of do a behavioral change, and those are available on, I think, on Psychology Net, or on, if you look up pacing worksheets for pain, you'll find plenty of them that are very effective for people to use when they need to kind of moderate their pain-inducing activity. And then there's other physical treatments such as IV and nasal ketamine that has been useful for pain, but also for psychiatric issues. Physical therapy and occupational therapy, chiropractic, acupuncture, massage, exercise. If you heard Kitty earlier say, in my practice, I have nutrition, psychotherapy, acupuncture. I used to have massage until the pandemic, but it's very useful for those with all sorts of different comorbidities, including pain. This is interesting. So these are some ER protocols that are non-opiate ER protocols. And if that's something that you're interested in having, you can look at, this is George Washington University. So you can take this down, or we can send this resource to you if you're interested in getting a more detailed non-opiate intervention for initial acute pain. This is what I was saying about the acetaminophen, ibuprofen fixed dose. This is for dental pain. There was another one for ortho pain, but anyway, another good article. Digital therapeutics, so Reset and Reset O, are for folks with substance use disorders, not for pain. But if someone has the crossroads of pain and addiction, especially opioid addiction, then Reset O can be indicated if they have a diagnosable opioid use disorder. And Reset O is only for those taking buprenorphine. Reset is for any individual that has substance use disorder of any type, except for if they only have alcohol or only have opioids. Anyway, it's an FDA approved, FDA authorized prescription digital application. So it's on your phone. So you get on your phone, the patient has this, they get a 12-week prescription that you have to write. It goes through cognitive behavioral therapy, fluency training, and contingency management. So they get prizes for doing the work that you're asking them to do. And then you get a dashboard to monitor their progress. And it's not to replace therapy, it's to augment therapy. And it can be really great for that busy clinician that knows their patient seeing a therapist, but you don't have time to kind of go through the meet with a therapist every week like you would if you're in the same team. But it's great to augment that. And then you can look at it, kind of every appointment go over, oh, I see you did this, this, and this. I see that on this week you dropped off, you had cravings on this week. It coincided with your drug use or whatever. So, but the outcomes are great. So 82% of patients that add Reset O to buprenorphine stay in treatment during the 12-week period versus 68% who did not add Reset O. So, so the outcomes are palatable. They're really, they're really present. It's a nice addition, and patients like it because they can use it 24/7. Here's a picture of, on the left-hand side, that's the patient's interface, and on the right-hand side, that's the doctor's interface or the clinician's interface. But it needs to be prescribed by a prescriber. And you can contact the Pear Therapeutics, you can contact them. Pacing, this is what I was talking about, and the VA uses this widely. You can actually check out this resource. But it's a skill to learn someone to be active without causing extra pain. So a lot of people in pain, they find themselves, frozen, or they don't want to be active because they're it's almost PTSD. But this allows them to increase activity, increase fitness, but feel less vulnerable to injury because they're actually not doing, 0 to 60. They're just, my example is like, they're not mowing the whole lawn. They're only mowing a quarter of the lawn. And then they're using psychological tools to allow themselves not to feel judged for not mowing the whole lawn in one day, or just giving them some acceptance. This is what I see. Dr. Mel Pohl in Vegas, he's excellent at dealing with pain and addiction. He has a couple of centers specifically for that, using a lot of the tools that I'm talking about, from both non-pharmaceutical to medication management, but not full agonist opioids. But the cycle is like a PTSD cycle. You got pain, then you have fear, then you have avoidance, more fear, decreased mobility, and then you have more inflammation and more stuck, and then you feel more that you have more self-esteem issues, diminished self-efficacy, and social limitations. So this is very valid for most people that suffer from chronic significant pain. And so I like to think about how we know who is at risk. I think about biology, stress, and drugs. So people that are at risk of addiction, people that are at risk not of, but like, let's say your pain patients that you might want to stratify into like who's at the high risk. Well, think about their genetics, ask their family history, look at maybe if you can the inborn errors of metabolism, or just think about that from really just how they present clinically in a family history. Epigenetics plays a key, but we don't have a diagnosis, or we don't have a biopsy for epigenetics. We have some markers, but that's not enough right now. Look at people's stress, especially trauma. If someone has an accident, they may still have nightmares. They may, if they have other non-pain medicine related traumas, it could be very fruitful to think about trauma therapy, or really investigate some of the traumas, especially PTSD. And then drugs. And the more access we have to drugs, the more likely someone is able to have access. So it seems like a simple piece of the formula, but the prescription drugs restricting has helped in some cases. But now we know that illicit is a much more available thing on most of our streets, particularly rural areas. So this is a little overview of who's at risk. And so, and even think about like bullying in the workplace, or violent, stressful relationships at home, or even poor nutrition can put someone at an environmental and a biological risk. So this is who's at risk. So the reason I think about who's at risk is I think about a risk stratification. If you're going to start someone in acute pain or in chronic pain on a full agonist opiate, which is, at your discretion, but let's risk stratify a little bit to really, and I know that pain physicians have guidelines of using certain risk stratifying tools, and of course having some acknowledgement and patient agreements. So for chronic pain, more accountability for people with chronic pain, definitely wanting to build trust and have regular office visits. Of course, we're in a pandemic time still, and a lot of us are still doing virtual, so that might not fit. But using all these treatments that I mentioned before, from the pharmaceutical to the non-pharmaceutical, can be so fruitful. All right, so I have a lot to go through in treatment and recovery. But this is the ASAM guideline for medication-assisted treatment of opioid use disorder. And let me say this: if anyone is requesting any of this information, we'll be able to get them to you, especially this part, the treatment guidelines. So I have a whole bunch of kind of like recipes almost, or suggestions. And they're from colleagues. They're well used, but they're not necessarily, an FDA or a CDC guideline. This is the American Society of Addiction Medicine guideline. But anyway, so you can get some of this to take home to actually, be able to peruse it much deeper and look at the original articles. But I also want to mention, as Kitty mentioned in the beginning, to put questions in the chat box, and we'll be able to get to some of those towards the end. Okay, so I want to always emphasize that both pain and addiction are chronic care diseases, and so a chronic care approach is essential. Using a multimodal treatment, as in not just one doctor, a doctor, a nurse, perhaps a therapist, perhaps a physical therapist, having lots of people that you refer to. My referral spreadsheet is a mile long. I have hundreds, if not I have so many different modalities on my referral spreadsheet because every patient's an individual and every patient needs something different. And when I find out what their needs are, I'm going to refer them to someone that is in my network of referrals. So if you're, a rural physician that is kind of in a standalone area and you don't have many referrals, now we can think of some virtual referrals, and also using, if they do have addiction, using things like digital therapeutics, but another non-pharma things. Treatment must address the multiple needs of the individual, not just the pain, not just the addiction. What I know is that if we just do the buprenorphine prescribing for opioid addiction, for example, that doesn't transform someone into wellness. Yeah, that props them up and hopefully helps them not overdose and not use heroin and not continue using or misusing pain pills, but that doesn't get them into wellness. And so we need to address the multiple needs just by asking what the needs are. Sleep, energy, a lot of people, actually, this is pertinent. I don't know if I have this anywhere on my slide set, but a lot of people, men and women, that are using opioids chronically, whether it's for pain or for opioid use disorder, for addiction, whether they're using them chronically, even if it's just as prescribed, even if it's buprenorphine. Buprenorphine and full agonist opiates do downregulate the hypothalamic pituitary axis, and so that can really just downregulate hormones. And so we need to check hormones if people are having hormone related symptoms. And so that's another great course of treatment or course of workup to help augment treatment and help them get well. Multiple courses of treatment might be required. So what we know is that the longer the time frame, the better the outcomes for both treatment and recovery of pain and opioid use disorder. But for opioid use disorder, i.e. addiction, relapse is likely, and we have relapses so frequently. And so we need to just make sure that that we attend to that and know that, expect relapse and have a plan in place to deal with relapse. So this is that continuum again. And so, those people can get over the withdrawal management hump, and we'll go over some tools to do that. But patients may then go back into the rest of the cycle. They may relapse and start again. And so it's just something to note that we need to address all of the different parts of the opioid use. So at the withdrawal state, so here's some treatment kind of recipes, like I said, for treating withdrawal. So OWS stands for opioid withdrawal syndrome. So there's a couple of things you can do. You can use alpha-2 agonists such as lofexidine. Lofexidine is indicated for opioid withdrawal syndrome. Clonidine is the one that most people are familiar with and they use, but it's not indicated. So I was supposed to tell you if I'm speaking off label, so I don't have clonidine listed here, but it is something that a lot of people use, but lofexidine is actually indicated. You can taper off if you're, I'm not a full agonist opioid prescriber, so I don't necessarily, I don't prescribe full agonist opioids, so I don't taper down. But like for a pain clinic, when it's time to change the medicine, we don't stop abruptly an opioid because people will have opioid withdrawal syndrome and look and relapse, even if they're not, or look for something else. But we taper, and we can use adjunctive comfort medications that are things that help with GI, things that help with sleep, things that help with the excitation. So a lot of people use a combination of gabapentin and bentyl and hydroxyzine, and then some sleep agents to help people through the withdrawal, whether the withdrawal is from misuse or whether it's from just trying to stop pain medicines that are prescribed and someone's taking exactly as prescribed. So you want to then consider a partial agonist or an antagonist for short or long-term maintenance. Like I said, if someone has, first of all, if someone's ever OD'd, I want them to have the opioid receptor covered for a while. If someone has has a risk of overdosing, I want them to have it. If someone has, chronic relapse, they're like, no, I want to stop. I'm going to stop. But then every time you see them, you have a positive drug screen for an opiate because they misused or they found a pain pill or they just don't have the compulsion under control. Then I want to cover the opioid receptor, and I cover that with either buprenorphine, a partial agonist, or naltrexone, an antagonist, which comes in the oral form, daily, 50 milligram, 1 to 2 PO. Or extended release injectable Vivitrol once a month, or an implant, which is pending FDA approval, but a lot of people are using it. If you're using an agonist, i.e. A full agonist opiate, even a partial agonist such as buprenorphine, watch for benzos. We know very well that benzodiazepines plus any opiate, whether it's a partial agonist such as buprenorphine, full agonist, morphine, oxycodone, methadone, benzos plus opioids lower the respiratory rate and are really what is associated with a lot of the overdoses. Not all, but a lot of overdoses, especially with buprenorphine, would be implicated from a benzo addition. Use your prescription monitoring program. All states have it, and I believe all states now have reciprocity with others. So for those that are in states that border other states, you can usually click to see what someone's been prescribed in a nearby state. Get your urine toxicology right. In-house cups are great. Also, send outs, have a contract with a lab that you can do send outs. Then decrease the access to substances of addiction and misuse. So one thing that I like to talk with all of my patients about, whether they're addiction patients or any patient, is please look in your medicine cabinet. Please see about removing things that you haven't taken, because your neighbor, your son's friend, if you're selling your house, the person coming over, your house sitter, your dog sitter, could look in there and they could have access to an opioid or benzo or something scheduled that could be harmful for them, or it could instigate their first use and then addiction. When I'm using benzodiazepines, I have patients bring in not just the medications that they have left in the box or in the bag, or whatever, however they get it filled at the pharmacy. I have them bring in the empty wrappers too. So they have to keep all of their empty wrappers. They take the buprenorphine, put it in their mouth, and then they keep the wrapper. And then if I had written for 28 in a month, then I should be able to count 28. And when I say I mean my nurse or therapist does this, or the assistant. But keeping that full empty wrapper is a great way to do medication counts. There's a much less misuse with that. So this is a little way to do a taper off of opiates. So first we think, okay, do they have an opioid use disorder? If so, admit to IOP. If considering Vivitrol, then what? If we haven't used in several days and they have minimal COWS scale, which is the rating scale that we use for opioid withdrawal symptoms, and they have a urine drug screen negative, then you can do 2 to 3 days of medically monitored withdrawal, and then the naloxone challenge, and then the Vivitrol injection. If their COWS is a little higher, then 4 to 5 days of medically supervised withdrawal, and then the naloxone challenge, and then Vivitrol injection. And then if they have used recently and you're wanting to put them on Vivitrol, then you have lots of options. You can start buprenorphine, titrating to 8, then 6, then 4, then 2, and then keep monitoring, and then 5 to 7 days of naloxone challenge, then Vivitrol withdrawal, then Vivitrol injection. So it's doable to get people onto Vivitrol even if they have recent use and they are not yet ready to get the naloxone or naltrexone challenge. Just so you know, I personally don't use the naloxone challenge for everybody. In fact, I sometimes use naltrexone, but I rely on a good communication, a good urine drug screen, including a fentanyl screen, and just some symptom management before I start the Vivitrol injection. So in order to taper off of opioids, and this is actually true for, this is what I was saying before, this can be for people with addiction, or with coming off of pain meds without addiction and just physiological withdrawal. You can add buprenorphine for a short taper. Without buprenorphine, you still want to treat the opioid withdrawal symptoms. So lofexidine, gabapentin, hydroxyzine, dicyclamine, and trazodone. So these are kind of a real basic recipe. And again, this will be something available to you all to have for you to peruse at home. All right, so buprenorphine products. For people with pain that are treating pain, folks, you don't actually need a waiver, an X number. If you're treating pain and that's their chief complaint and that's what they're coming to you for, and you're not a psychiatrist, if you're a psychiatrist, you have to be usually, it's better to be in a specialty pain program that you're working with. And so no waiver is required to use Buprenex, Butrans, or Belbuca. And also there is, I think, another type of buprenorphine product. For addiction, opioid use disorder, there is an X waiver required. So for me, because the Harrison Act in 1914, I have to have an X waiver. Now, just the other day, we had a new availability for folks that don't want to do the training to get the X number. You can apply for the X waiver and through SAMHSA, and you can get an X waiver, and you can prescribe up to 30 people in a month. So, which is great. So you can get them started. And then if you need to then move them over into an addiction specific clinic, then you can move them over. But your X waiver, you still have to have an X waiver, which is confusing because the way it was released, it sounded like you didn't, but you still have to have an X waiver. However, you can prescribe only to 30. And for those of us with the X waiver and the training, which is 8 hours for physicians and I think 24 or 14 for nurse practitioners and PAs, then you can prescribe up to 100 and in some cases up to 275 at any given time. So Suboxone, Bunavail, Zubsolv, Sublocade injection once a month, Perbufen implant, and Brixadi injection. Those all are the forms available of buprenorphine products. Okay, so I've talked a lot about buprenorphine. It's a partial opioid agonist. It's been around since 2003. It's Schedule 3 instead of 2, like a lot of our medicines are. It has a ceiling effect. And just so you know, partial agonist doesn't mean partially effective. Key. So it's very effective, but it's a partial agonist, and that means that it has a lower rate of overdose or lower risk of overdose. And it's approved and indicated for opioid detox and opioid maintenance, opioid use disorder maintenance. And as in addiction, we just say longer equals better outcomes. All right, I've got tons of slides to go through. I just need to, but I want to make sure I have time for questions. So I'm going to just kind of fly through this. These are some questions. If someone, this is the biggest question I get, if someone is steady on buprenorphine for addiction and they have to go into a surgery or have some sort of pain management, the easiest thing to do is to continue the buccal sublingual buprenorphine, and then you can add things with high binding affinities such as fentanyl, not you, but the surgeon, or maybe you're the surgeon and you're trying to figure out what to do, or you're in the post-op. You can add IV buprenorphine, and you can use other forms of buprenorphine, such as Belbuca, and even fentanyl and hydromorphone work hand in hand as long as people are monitored. That's not a home dosing. This is someone in the perioperative traumatic period. Sublingual buprenorphine for pain is oftentimes used off-label. So because the ones that are in those two lists, the list of those for addiction versus the list for those for pain, we have to take into consideration the DEA. The DEA has, when we have an X number, they look very much upon us. We don't use off-label that frequently, but there's so much that many of my patients have both pain and addiction. And so they know that the buprenorphine is treating their pain, but I'm using it for addiction. And they're diagnosed with opioid use disorder in order to get it approved for their insurance. So we have to just think about off-label use. And so this is just a comment on that. There's a lot of literature on sublingual buprenorphine for pain relief. And so the FDA does say that it permits the use of sublingual bup as an off-label analgesic. despite common perception. And so I'm not suggesting that you go cavalier and do this, but this is just some understanding of what it is. It really does have an analgesic effect. So because sometimes opioids have hyperalgesia after you come off the opioid, but buprenorphine doesn't seem to have that. So this is one of my ASAM directors. I'm going to give him credit for this, Mike Miller. He says to write for pain in the instructions. He trained me on this, but some pharmacies won't fill it without the X number. So it's just superior to have an X number if you're going to be prescribing buprenorphine, unless you're prescribing the ones specifically that are formulated for pain doctors, such as Belbuca. So anytime you're transitioning from a full agonist to a partial agonist, when do you start the buprenorphine? You want to start it when the cow's scale is a little bit elevated. So the red and green are the cow's scales. So you want to start it when you start having numbers on the cow's scale or just symptoms, because the buprenorphine binds tighter than heroin. And so if you start it too early, it'll put someone into a precipitated withdrawal. Okay, I'm gonna go through, this is a lot of slides and we're gonna just fly through these. Know that you can have these to take home with you if that's interesting for you. So this is, like I said, kind of the recipes. This is about microinduction, because microinduction, even though it's a little bit off label, is something that is done in clinical practice. And for those of us with a lot of experience, we find that we do smaller dose inductions because of this concern of the precipitated withdrawal and being able to really control and figure out what dose we actually need. Because buprenorphine is effective for both an analgesic and opioid use disorder. So when we hit the crossroads of pain and addiction, this is a really great idea. Okay, so this is someone on what we would consider a medium to low morphine equivalent, and this is how you might consider inducing or inducting the buccal buprenorphine. And I keep going. And again, like I said, I want to get to questions, and these are for you to take home. Okay, so take home pearls. Physiological dependence is not addiction. Do treat the pain. And if we're depending whether you're a family practice physician or a addiction specialist or a pain specialist, we all know that we do need to treat the pain, but we don't necessarily need to treat the pain only with pain pills, because although we were taught to treat pain and treat it hard and treat the fifth vital sign of pain, we know now that that can put people at peril if that's the only thing they get. So treat pain, treat it with all of the things that I had talked about, with all the augmenters. Opioids might not be the only pain management strategy. There are taper strategies for people who are on full agonist opioids, such as heroin and pain pills, including comfort meds and buprenorphine. If patient has opioid addiction, and I say bona fide opioid addiction, cover that opioid receptor after stopping because of the behaviors and also when someone's opioid naive and they're off of an opiate for a period, they're at risk for, they're opiate naive, and they're going to have a higher risk of an overdose. And it's really scary for me. So I worry, I stay up at night if I don't have the new, the patients with addiction to opioids, opioid receptor covered. A lot of alternative strategies are actually more effective than opioids for pain. Partial agonist opioids are something to use. Every single person that has ever overdosed, every single person that has a risk of overdose, I make sure that I prescribe them naloxone. Different states have different ways of proving naloxone, but most states have gotten to a place where naloxone can be gotten without a prescription at the pharmacy, at certain pharmacies that are participating. But if you're the prescriber and you're working on someone that you know that they've overdosed, highly recommend, not even highly recommend, I request and implore you to prescribe naloxone. And that person might not use it themselves, but they might use it for their loved one or their neighbor, and it can be it's a lifesaver, as you know. By the way, I just received a 300 oysters for a weekend oyster shucking thing that we're having. So they just came in FedEx just now. So this is my little oyster and pearl homage to our Louisiana oysters. All right, so this is interesting. Really quickly, there is a vaccine in the works. Dr. Sharon Levy and I did some work together, and I found out that she and her husband have been working, he's an immunologist, they've been working on an actual vaccine to prevent opioid overdose. Whoops. So really interesting stuff. It's on a clinical trial right now, and it sounds pretty promising. So, all right, now we have questions. Thank you so much, and I look forward to answering some questions.
All right, and you can place the questions in the Q&A box if you have any questions, and I will read them.
If there aren't questions yet, then I'm actually going to go to this one slide just so that people can see this again, and maybe we can include this in what we send to folks that request any sort of literature or references, because this has just an overview of those things that are non-pharmaceutical treatments. So just a reminder that we have loads of non-pharmaceuticals and pharmaceuticals that are not opioids that help with pain management. And this can be for those that are using opioid pain pills for pain management and they have other things going on, or they need to, have augmentation with anti-inflammatory agents and such.
All right, still no questions.
Okay, well, good.
Okay.
Well,
oh, here we go. Do you have any specific recommendations for PCPs that are interested in starting to prescribe buprenorphine for their patients' pain management?
So we can go to some of these. For pain management, there are loads of guidelines. I would definitely get with, honestly, Buprenex, Butrans, Belbuca, get with the pharmaceutical companies that make those, get their literature, and then read on some of the dosing guidelines for them. So I think that would be probably the first place I would start if I were jumping into using these. Again, what I presented on, because I'm an ex-waivered psychiatrist with addiction management training, I use buprenorphine frequently, but from the ones on the left-hand column, but I don't have access to the ones on the right-hand column. So I use them, and I don't use them exactly off-label for pain because my patients are diagnosed with OUD, but they are treating pain. So you can foray into that as and this will be, let's see. So this is a great research article. If you'd like to take that, you can read there. But I would also recommend that you get in touch with your pharmaceutical agencies or pharmaceutical reps that do those three medicines. And I can tell you that in Louisiana, on the left-hand side, most of these are covered by Medicaid and Medicare, or covered by Medicaid. And on the right-hand side, I'm not positive what's covered. I know some of them are covered. So that's a really good thing to note, because we have to, figure out where our patients are at from a financial perspective. And if their insurance is going to cover something. Of course, if their insurance doesn't cover something, then we're intending to do a good job, but we're not really helping the patient in the fullest capacity.
All right, thank you. We have one more question. What dose for buprenorphine do you recommend starting with for an ED induction?
Yeah, so if it depends on where they are in their withdrawal. So getting that COWS scale and making sure that they're at least at an 11 or 12, maybe 14 on the COWS scale, which is a very simple COWS, clinical opioid withdrawal syndrome. It's a simple checklist that that even a non, like a nurse assistant or an MA can do. And so getting them to that, and then I usually start, if I have the 4 milligrams available, depending on how much they were using, assuming they're in the ER, that you're using a decent amount and you're in decent withdrawal. I usually start with 4 milligrams of buprenorphine in the form of Suboxone, because it comes in films and it's easy to break and cut. Whereas Zubsolv comes in a pill and it's a tablet and it's impossible to cut. And then of course the injectables you wouldn't do that with. So I usually start with 4, wait 2 hours, and then have a nurse check and see if they're do their COWS scale, and then go back and add another 4. And depending on what I find is people that use, like, let's say 5 grams of heroin a day, I'm going to need them on at least 16 to 24 milligrams of buprenorphine a day after a couple of days to cover that. And then maybe in a week or a month we'll go down. But for people that use 1 gram of heroin, or, you know, this is kind of the like 50 or less morphine milligram equivalents, then I usually find 8 to 14 milligrams of buprenorphine is successful. So this is the microdosing, and it's really hard to get these into this microdose numbers, because if you're not using a liquid, then it's almost impossible. But this is still kind of some microdosing ideas.
All right, any more questions? Great, well, so this video is going to be made available on the SIU School of Medicine Continuing Professional Development website in about a month, so you can review it then again. And we will be sending out the PowerPoint slides. I want to thank Dr. Podesta so much for presenting today. This was an extremely interesting presentation. So I will be sending out an email. You'll receive it from SIU School of Medicine, and requesting information about the CMEs or CEUs that you are needing. So thank you again, everyone, for joining us.
Thank you. Really wonderful to do this presentation for you all.
All right. Bye-bye, everyone.